So our session today, we have Carl Philpott on. Carl is a professor of olfactology and rhinology. Carl set up the country's first smell and taste disorder clinic. And this was only, Carl, I'm sure you'll come and collect us, but roughly say 10 years ago. And that's a fact that I always find extraordinary, that here, a consultant coming up through found that there was a gap, that one of our senses, our sense of smell, and therefore related our sense of taste as well, didn't have a specialization around it. Of course, there are lots of different pieces that go into it, but that single point of contact to bring all of that different knowledge in there together hadn't existed. Carl set that up, and Carl will take you through then as well the history of the contact of fifth sense. Now, as we're going through the session today, please do hope you can find the chat box. Pop in any questions that you have as we go, and at various different points during the session I will scoop up those questions and have a chance for a Q&A with Carl as we go through. Carl, over to you. Very warm welcome.
Thanks, Tom. Thanks for the introduction. Good afternoon, everyone, and thank you for tuning in. In my sort of involvement with smell and taste disorders really stems back to a research project that I was given as a trainee, and I was basically starting off in ear, nose and throat surgery as a junior doctor. My consultant said, well, if you're interested in getting involved in the specialty, you ought to take on a research project, and I'm been busy developing this kind of apparatus for testing the sense of smell, so why don't you get involved with the project? And the process of writing up my research, I started to realize that actually this was very much an area that was untapped and undertreated in the UK, and for that matter internationally. And it led me to find out there was a course in Dresden under the guise of Professor Thomas Hummel. So I went over and did a week's immersive course in smell over there in August of 2005, I think it was. And at the end of the course, he said, oh, you must come back and spend some time with us. And so 2 years later, I went back and spent a month doing a mini fellowship with him, and then really kind of saw it as my sort of goal to realize having a smell and taste clinic as part of my consultant work when I finished training. But, you know, one of the things that's key to that, and I guess one of the importance of today's talk, is really to sort of understand the role of research, because there's a lot we've yet to learn, and a lot we've yet to do in terms of providing treatments for smell and taste disorders. So let me share my slides.
Oh, just before you get into the research piece, just because I do notice we have a few people, I mean, a lot of us, of course, have been immersed in smell and taste disorders, what they mean, where they come from for a number of years. But I'm sure we have people as well, I know we do, because we've got some people who've are post-COVID. Just make sure we're all on the same sort of starting point. Can you just take us through some of the, just a very, very brief summary of the basics, the relationship between smell and taste? Why do we call them smell and taste disorders, for instance?
Yeah, so obviously sense of smell relates to what we're doing with our nose, and there are two ways we smell in essence. One's the passage of air from the outside of our nose. So when you sniff in, you draw air upwards, and about 15% of the air that goes into your nose reaches the smell receptors at the top of your nose, and allows the molecules of smells to reach those receptors as they dissolve through the mucus. That's what we call orthonasal olfaction. And then there's also the process called retronasal olfaction, which is what happens when we're eating food. And when you've got food inside your mouth, actually the odor of the food, you can essentially breathe it back out through your nose over the smell receptors. And you do that at the same time as you taste. And taste from a medical perspective is what we do with the tongue, although there are also taste buds around the top part of the throat and the soft palate. And those taste receptors pick up things like salt, sweet, sour, bitter, and a savoury sensation that's known as umami. And those are quite basic sensations. And because we taste and smell in parallel, most people sort of struggle to separate these two out because you do them together. And so you often hear people talk about things like a sweet smell. For vanilla, for instance, gets talked about as a sweet smell because inevitably when you're experiencing vanilla, you're often experiencing in something sweet as a pudding, for instance, and so those two things happen in parallel. Of course, for those of you that have experienced smell loss, you'll perhaps think that you lost taste, and many of you, I suspect, will be able to pick up things with your tongue, such as I've just described. For those of us who can smell normally, the way to kind of understand the separation is to pinch our noses when there's food in our mouth, and a good one's a skittle test. So you put a flavoured skittle into your mouth. What do you taste with with your nose pinch and the skittle in your mouth? What you normally get is sweet. If you unpinch your nose and allow the air to circulate from the back of your mouth into the nose, you'll get the flavour of the sweet, which is usually then the strawberry or the apple or whatever it might be. So that's a common sort of misperception that people have around the word taste, and really we should talk about flavour perception when we're talking about the two things happening together in practice.
Excellent. And I don't want to sort of encroach on what you're going through in a moment, but I put up those basic ways that it can go wrong, where we can lose or get distortions of our sense of smell and taste, so our flavour perception and smell. Broadly, what are some of the background reasons for especially in the work you see in your clinic, as to why people might lose their sense of smell?
So I look at it from two perspectives. We look at the sort of general community at large. The most common reason for smell loss is chronic sinus disease, the chronic sinusitis. If you look at the sort of work I do in my clinic, then I do see a lot of chronic sinusitis. But if you look at the people specifically coming around the sense of smell, that probably accounts for about up to a quarter of the cases. Another quarter of the cases that I typically see in the smell and taste clinic are for people who have had an upper respiratory infection, such as a common cold, viral infection. Sometimes those infections might be bacterial, otherwise in nature, but typically viral. And the sense of smell hasn't come back after the other symptoms have disappeared. Of course, we're seeing that with coronavirus as a symptom of the pandemic. And then head injury is another group. But the other big group I see a lot of is the people that don't have any obvious cause in their history, nothing in their medical history, nothing that's happened before the smell loss. And we do all our investigations, we find nothing either. And they're what we call idiopathic cases.
Thank you.
Right, okay, so what I thought I'd do to start off with is talk a little bit about the history of Fifth Sense and its involvement in research as a charity. For those of us involved in medical research, one of the most important things now, if you're writing a grant application, particularly to funding bodies like the National Institute of Health Research, is that you've involved the public and patient in your application, and they have a stake in what you're going to do as part of your research. So it's really a critical component of any funding application, and I've now sort of seen a number of times where that public and patient involvement has been key and has sort of shaped the end product of what we've sort of come out with as part of the application. So looking at the sort of timeline for Fifth Sense, I mean, Fifth Sense had its beginnings, I guess, back in 2011 when Duncan Boak, as the founding member, after reading the book Season to Taste by Molly Birnbaum, happened to contact Thomas Hummel. And of course, as I mentioned, I had already had a connection with Thomas Hummel from some time back, and Thomas said, well, you go and have a talk to Carl. And so Duncan and I sort of were talking about what there was in terms of support for patients, and I said, well, one of the things I've been thinking that's needed is a patient support group. And he said, well, I'll take your patient support group and I'll raise you a charity. And the following year, 2012, we did our first public engagement event, which was in Norwich, the St Andrews Halls. And I guess that was our first opportunity to get feedback from those people that were affected by these disorders. Moved things on 2 years later, and together with some colleagues, we were putting together a team for a research called the Macro Programme around chronic rhinosinusitis. And we needed a representative to represent patients, and Jim Boardman of Fifth Sense was the person to come forward and be part of the team. And he's then been very much involved since then, because he's part of the research team, so he comes to the research meetings and he kind of advises us from a patient perspective. As part of that process, 2 years on, because the build up to applying for funding is about a 2-year cycle. As you prepare the application, you submit it to the first round, it comes back, and then you go around to the second round, and then you wait to hear if you've been successful. That process took about 2 years, and in 2016, when we found out we got the funding, we also formed the PPI panel, and Jim oversaw that to have a group of people who could comment on things like the patient information leaflets, the information that was given to patients about the trial, stuff that goes on the website, so that it was all designed to be available in a friendly manner for people that weren't medically trained to understand and read. Since then, Jim certainly got involved as a representative for SENS with other work through the National Institute of Health Research. We have a national group that oversees work done by the Clinical Research Network. One of the great things in the UK that we have that other countries don't have is this thing called the Clinical Research Network. And basically what it does is it means that any research project that's adopted onto what we call the national portfolio, so a sort of roll of projects that is undertaken in research nationally in any specialty, the network allows support to come in and for individual sites to get a research nurse or support locally to deliver that research. That infrastructure is really crucial. And we have a network meeting where we discuss all the ear, nose and throat research that's going on and any problems that are being faced and anything we can do to support that. And so again, public and patient input to those is often crucial, because they may have ideas of why a particular study is not recruiting so well, for instance. Bring us forward to 2020. We've had this group called the the Global Chemosensory Consortium for Research that formed after the pandemic started. And it's a group of people from lots of different backgrounds in the smell and taste world around the world that have come together to have a survey that's gathered information around smell and taste disorders in COVID-19. And so Fifth Sense had a stake in that because Nina, our new national director, has been a part of the UK group and more recently part of the leadership team. One of the things I'll come on to is we're about to launch a priority setting partnership, and I'll talk more about that shortly. This has also contributed towards guidelines on treatment for smell and taste disorders, particularly around COVID-19. So, gone backwards. So over the sort of last 8 years since Fifth Sense formed, we've had a number of conferences and either in conjunction with those or separately, we've done a number of surveys. And that's allowed us to get lots of useful background information around the sort of problems that are faced by patients with smell and taste disorders. Some of our surveys include one on quality of life issues, one on parosmia and phantosmia, and the most recent one that was facilitated by Newcastle University on access to healthcare for people with smell and taste disorders. And so I'll give a few examples here of some of the things we've been able to publish as a result of this. Now, this one's actually with a journal at the moment, so this is a kind of snapshot of something that's coming. This is one we published at the beginning of the year. This is one we published at the end of last year. That was about a questionnaire for smell and taste disorders. This is part of the work from the macro program that Jim Boardman's contributed to. And this was the original one that Duncan and I published back in 2014, which was really on the back of about 500 respondents from Fifth Sense membership. So as I mentioned, we've recently been successful in securing a priority setting partnership for smell and taste disorders through the James Lind Alliance. Now the James Lind Alliance run a process for trying to recognise and formalise what research priorities should be for particular conditions or areas in the medical domain. And they've been doing this now for over a decade, I think. And we thought back in the sort of early stages of fifth sense formation that this was something we needed to do, but it's a process that has to be funded. And so obviously more recently, you may be aware that we secured some lottery funding from the National Lottery scheme, and that allowed us to be able to fund this process of the priority setting partnership. And so on this Friday, we're going to be doing our first steering committee meeting, and then from that, we're going to be sort of engaging the body of anyone that's got any connection to smell and taste disorders. So that's sort of patients, clinicians, pharmaceutical companies, research organisations, NHS managers, so anyone that might have a stake in the process to try and bring up a list, and it'll be initially a very long list of potential research priorities, and then our work over the next year is to hone that list down until we end up with a top 10, and that top 10 will be the thing that we announce hopefully at next year's Fifth Sense conference, which we hope will be held in autumn of 2021. And I sincerely hope that it'll be something we'll be able to do face to face rather than in a remote fashion by next year, but let's see.
And Carl, there's a lot of work going in behind the scenes on that. What's your hope for what the benefits will be to people who do suffer from smell and taste disorders from the priority setting partnership?
So one of the key things is that it flags up to funding bodies a list of key priorities that's really been thought about quite carefully by everyone that has an input. So as I mentioned at the beginning, obviously public and patient involvement in research is now a crucial component. And if you've done that process already, it says a lot to sort of a funding body to say, okay, here's something that's important to the patients, the clinicians agree, therefore this is something that should be prioritised. And so the James Lind Alliance is now under the banner of the National Institute of Health Research, although it's a slightly autonomous sort of organisation within that. But it does mean that the NIHR will look at the lists that they publish once these processes are complete, and they might then commission research. Now, the way that the NIHR works is there's two main ways to fund research. There's the commission route, and then there's the sort of competition route. So most of us are used to kind of applying in competition, and we then go to head with all the other specialties. So I might apply for £250,000 of research funding and be up against diabetes, stroke, and heart attacks. And you might say, therefore, that's kind of slightly unfair competition, because people might view that this a higher priority for those. So the commissioned research sort of approach is an opportunity for the funding bodies to go, okay, well, we think actually there's a value in funding this, so we'll put out a commissioned call, and then they say that they're actually then going to fund that bit of research, but the competition is around who will do it. And so it's then there's a sort of bidding process. So you put in your application, and then you have competing teams who bid to win the funding that's available. So that's a key advantage that can come out of this.
So it sounds like there's going to be a much more direct route in between the beneficiaries of fifth sense beneficiaries and research. It sounds like a much stronger connection than it has been.
Yes, exactly, that's right. And the idea is that in the final workshop, we'll also invite industry partners and commercial agencies who may also look to kind of say, okay, we're a pharmaceutical company, we've got drug A, we think actually we can see that priority you've got on your list, and we can sort of take that and run with it and offer to fund that. So it's also an opportunity to bring in potential commercial sponsors, which is also beneficial.
Brilliant.
So what I've got on this slide is a little bit of a clip actually from the JLA. So I'll play this because this probably tells you a bit more in detail. This plays okay.
The James Lind Alliance, or JLA, provides a method that brings patients, carers and health and social care professionals together in priority setting partnerships, or PSPs, to set the top 10 priorities for research in a particular area of health. The views of people who live with medical conditions and those who treat and care for them provide important insights into people's needs, preferences and priorities. Getting their perspectives helps to make sure that the right research is being done and that we're making the best use of valuable research funding. Often the priorities of patients and those who care for them can be very different to those of researchers and funders. The first step in a priority setting partnership is to bring together a steering group to oversee the process. It's a small group including people who represent patients, carers and health professionals. The group works with an independent JLA advisor to support and guide the process to ensure that everyone can have their say and that JLA principles are followed. The next step is for the PSP to gather questions from patients, carers and healthcare professionals about their particular health area. For example, people have asked, what's the best way to treat my acne scars? Should I recommend breathing exercises for my asthma patients? Fear of falling really makes my older patients anxious. How can I best help with that? PSPs typically do this using an online survey which they publicise to make sure that a wide range of patients, carers and health professionals hear about the survey and complete it. Once the survey is complete, the PSP will create a long list of summary questions from the responses that people have given them. They will check the questions against current research evidence to make sure they haven't already been answered. Any questions that have been answered and don't need further research are removed from the list. The long list of unanswered questions is put into another online survey where patients, carers and healthcare professionals are asked to choose their most important questions based on their experience. This helps the PSP narrow down the long list of questions into a shorter list. The final stage of the priority setting partnership is a one-day workshop where up to 30 patients, carers and healthcare professionals come together to share their experiences and knowledge and jointly agree the final top 10 most important questions for research. The PSP will then work hard to publish and promote the top 10 to research funders and researchers. The JLA method therefore highlights research questions of direct relevance and potential benefit to patients and the clinicians who treat them, with the aim of influencing the way research funds are granted. The JLA PSP process takes around 12 to 18 months. You can find out lots more about this on our website at www.jla.nihr.ac.uk. You can see us on Twitter by following @LindaLyons.
Okay, so hopefully that gives a nice overview of what's ahead of us in terms of the PSP, and it's exciting, really. It's I look forward to seeing what comes out, because I guess I have in my mind what I think are probably important things that I see in the patients that I treat week in, week out. But obviously, that as a melting pot of ideas comes together, it'd be interesting to see what we come up with at the end of that.
Thank you. So we've got a few questions coming in. I guess you're going to go on to understanding chronic rhinosinusitis. So I think let's go into this.
Yeah.
Let's go straight into this one, and then we'll pick up any questions that are related to it just afterwards.
Okay, so I thought I'd sort of specifically do a little sort of mention of the macro program, because obviously this has been a key one, as mentioned already, that has had public and patient involvement and is current research in the field. So as I said, chronic rhinosinusitis is the most common cause for loss of smell, particularly in those patients who form nasal polyps. And so we have this sort of horrible inflammatory disorder which affects the sinuses principally, but tends to encroach upon the nose as well. Typically, we've always divided that into patients who form polyps and those that don't. So you can see on the right-hand picture, glistening polyps in the nasal cavity. You can see on the left, purulent discharge and sort of infective discharge from the sinuses. And when we do a CT scan, you get this kind of classical picture where rather than nice black healthy sinuses with black on a scan is air, you've got all this completely congested blocked nose and sinuses. And therefore you can see why one of the prime reasons people can't smell is because there's a physical barrier between air getting to the top of the nose. But over a long period of time, actually other things can develop and cause problems with the sense of smell as well. So because it's the most common thing, obviously we sort of made a beeline for getting this addressed and funded and research underway. And as I mentioned already, the process of doing that was quite lengthy. And although the initial sort of planning period was 2 years, in reality, most of us in the team probably had a build up to that of about 5 years to get to where we needed to be. So none of these things are a quick process. The program itself is a 7-year program, including a clinical trial. So the idea is that we're going to address major deficiencies in the evidence base for the management of adults with this condition, to establish best practice, at the end of it design the best patient pathway across both primary, so that's GP care, and then secondary care, what happens in hospitals. And we know at the outset of this that practice around this condition is variable around the country, both in terms of the medical practice and the surgical practice. And that's one of the things that we've seen come out of the early part of the program, where we interviewed patients, we interviewed ENT surgeons, interviewed GP practitioners around their views on the disease, how they manage it, and whether they adhere to guidelines that are currently available. So the trial we're doing at the moment, or I say we're doing at the moment, it's because it's on hold. It went on hold when the pandemic hit at the end of March, and we're hoping to reopen in October. Basically takes patients who have had baseline medical therapy, and by baseline we mean nasal rinsing and nasal steroids, and are still looking for improvement in symptoms. And because two of the things that are available to us for which the evidence is not clear-cut are the use of long-term antibiotics. Well, I say long-term, that's over a 3-month period. Principally a group of antibiotics called macrolides, and in this trial we're using one called clarithromycin. Clarithromycin, the dose we're using in the trial, is designed to reduce swelling in the sinuses rather than principally to kill bacteria. So it's a slightly different sort of mode of action than as a primary antibiotic. And then we've got a group that received placebo, so that's a blank equivalent. So most clinical trials you do, in order to show that the active tablet has superiority, you have to have a sort of blank drug to compare it against. But in this trial, because one of the things we also need to look at with sinus surgery is that we've got another arm that's actually got people receiving sinus surgery. You'd think actually we'd know whether or not sinus surgery works, and many of us that practice sinus surgery see good benefits from that. But again, in a trial setting, the evidence wasn't there to say that sinus surgery is proven to be better than medical treatment alone. And as such, at the moment, we face commissioning bodies. Those are the bodies that oversee what gets funded in hospitals in terms of secondary healthcare, questioning the role of sinus surgery, saying it's something that they think shouldn't be funded. And that's because there's a lack of evidence in terms of trials to support it. So we've actually just written a letter from the research team to one of the bodies overseeing what operations should be considered unnecessary, to say, hang on a minute, because we're doing this trial, please wait for the trial to finish, because we need to show that the evidence is there one way or the other to support the role of sinus surgery. So patients entering the trial will go through a 6-month treatment period, but we're then asking them to be followed up remotely through questionnaires completed electronically for a 5-year period. And it's that length of time that you have to be able to follow people up for this condition, because it's such a long-term condition, to understand the real benefits from the interventions that we're looking at. So before COVID hit, we were actually doing quite well. At sort of end of February, early March, we were just below our sort of recruitment targets. We were opening up all our sites around the country. Our target was to have 17, 18 sites open, and we'd got to about 14 sites. So unfortunately, that all came to a grinding halt. And as such, we've obviously fallen away from our blue line, which is our target recruitment. So we're actually looking to recruit 600 patients for this trial. So any trial that you do has what we call a power calculation. That's the number of patients that has to participate in order to show a significant benefit from the treatments you're looking at. So it's what we call a statistical significance to the results. And so 600 is our target number. So we were about a quarter of the way there when things stopped. And I'm hopeful that we may get to restart next month, but with the current escalation of coronavirus cases, we'll have to see whether that dents our opportunity to get things back on track. Do you want to pause at that point for questions, Tom?
Yeah, we've got lots of questions coming in about treatments that people can try. So we've got some various ones, for instance, steroids or vitamins or antibiotics as well. I just want to get those questions in at the right point. Can we chuck those in now?
Yeah, if you like, yeah.
I have to what the rest of Carl's presentation is in case you haven't looked at it. So just a general one from Nigel. I guess we can give quite a short answer. Is there any sign of new investment in the field given the significant number of people around COVID? I know that this particular, the macro trial, for example, is one that's been going on for a few years to build up to this particular point. Any new areas of research opening up and focus on this?
In terms of seeing funding injected into the field, I'd say watch this space. So I haven't seen any kind of great rush funding to come in specifically for smell loss. It has thrown a spotlight on smell loss in a greater way. If there's ever been a silver lining to a cloud, then I'd say that it certainly has opened people's attention to what smell loss is like, even if people have experienced it on a short-term fashion.
Yeah.
So I think that can only be a good thing to sort of help for those of us that are trying to sort of highlight the case of smell loss. Yeah. But yes, so in terms of funding for that sort of research activity, that's yet to sort of translate through. But I kind of feel that the prioritizing process will help to sort of continue that momentum and build upon that. And perhaps by this time next year, we'll see that perhaps more investment will happen in research in this area.
Thank you. And some questions, because of course then we've got the viral and bacterial, both of which you've touched upon. Question from Mike saying he takes amoxicillin and smell returns, but then disappears after a few weeks. Do you see that as a common?
Yeah, it's a common thing I hear from patients who suffer with chronic rhinosinusitis. So it's sort of a temporarily ameliorating the sort of the soup of organisms inside their nose. Chronic rhinosinusitis isn't considered an infection, but a sort of inflammatory disorder. And we think increasingly that it's perhaps a disturbance of good bacteria and bad bacteria in your nose. You may have heard this concept talked about in the gut. That sort of, that sort of, there's an imbalance that happens, and you can sort of temporarily correct that, but it sort of, that returns again. So yeah, I often hear people talk about saying, I get sort of brief improvements with short courses of antibiotics. It usually suggests that there's sort of more that needs to be done for those individuals, and so I would say if depending on where you are with the treatment cycle, if it sounds like there's room for improvement, get a referral, get things looked at in more detail, and perhaps you may want to consider the trial as a participant if that's appropriate.
Just very briefly, because you mentioned it, are there any direct treatments in the same ways we can have probiotics for the guts? Given that to my son at the moment, he's been on.
The jury's out on that at the moment. Actually, interestingly, as a sort of side product to the trial, we are looking to liaise with a team in New Zealand who are experts on the sinus microbiome or the nasal microbiome. We're going to be sending samples from consenting patients who are part of the trial for them to analyse and look at in more detail. And they look at the actual sort of the DNA of the bacteria and look more. They have a more accurate way of assessing what's going on inside in terms of the changes in the flora that's happening in our nose and sinuses. And they'll see whether that kind of what we're doing in the trial makes a difference to that.
Thank you. Other treatments we've got had questions around any particular vitamins or minerals that people can take when you're experienced that might make a difference. I haven't got whether that's to anosmia, phantosmia, what the actual underlying is on that one. Vitamin A came up in a few questions.
So yeah, vitamins. I mean, I'll just briefly mention. So vitamin D we commonly find as a present as a deficiency in patients with chronic rhinosinusitis in about a quarter of patients, and that's not related to where you are, because I know that colleagues in Greece see it as much as we do. Uh, so the Mediterranean sun doesn't help the situation. So we think that the vitamin D gets reduced because in more severe cases there's depletion of vitamin D levels. So that is worth sort of checking out if you have chronic sinusitis. Vitamin A you mentioned, I'll perhaps touch upon that, come back to that later in the slides.
Okay.
All I would say generally about vitamins is that it's best to find out if you've got a deficiency and treat it rather than just sort of taking stuff at random.
Gotcha.
But multivitamins are usually fairly sort of simple things to take over the counter if you choose to do so.
Just another couple then, if I can just chuck into it once. A few people have talked about steroids. How long can you take steroids? What steroids are useful? I know that's an enormous subject to open up in a brief moment. But then also just an alternative one as well. Who put that in? Alison put that in about exercise after running. And I know that's one you've mentioned before as well, having a sort of a brief opening or improvement that can happen after that.
Yeah, so steroids in a nutshell, oral steroids, obviously we try and limit to short courses because oral steroids in long courses have potential side effects in the rest of the body. So high blood pressure, high blood sugar, thinning of the bones as being the key ones. Steroids going into the nose, on the whole, are only absorbed in the nose and don't go elsewhere. Patients who need to take them long term for chronic sinusitis, much as for asthma, shouldn't be discouraged from taking them, week in, week out, year after year. But I generally have a rule of thumb that if people are on them for 5 years, I tend to get them a bone scan and an eye check just to make sure they're not having any issues with that. It's very rare that we find anything, so they're on the whole generally safe to use in long term. But obviously, everyone as an individual patient should be taken on their own merit and in terms of their own medical history. The exercise one, yeah, I hear a lot of people talk about how exercise improves smell, particularly in those, again, with sinus disease, probably because they just sort of, if they've got polyps there, things are moving around inside the nose a bit when they're breathing in. Also, I guess when you're exercising, you're increasing air intake through your nose, so therefore the chance of increasing the air that's going to your smell receptors is higher as well.
Few more questions in there. Let me come back to those maybe after your next set of slides.
Okay. So I touched upon this before, but the Gccr survey is something that got going in about March time as the pandemic was hitting around the world. And you can see there from the map that we've got members from around the globe that are contributing, so both clinicians, psychologists, flavorists, perfumers, or people from all sorts of different backgrounds are involved in smell and taste. So there's about over 450 people that are now sort of part of that consortium. And so we've been running this survey, which you can see there's a website for, and that's now collected about over 40,000 responses globally. So we published one bit of work earlier this year, and there's another one that's under review at the moment. And we're just to be able to kind of characterize in more detail people's experience of what smell and taste loss has been like in coronavirus. And it gives you useful baseline information that can sort of underpin future research initiatives. So the existing publication that's out there showed that it was based on just over 4,000 participants. Nearly 3,000 of those were women. And as we typically see when we do studies on smell loss, we typically see twice as many women come forward as men. If you actually go out and sample people in the community and look at smell loss at the coalface, if you like, men are worse affected than women. But it's women are much more inclined to come forward than men when they talk about smell loss, and that we see that time and time again with the research in the field. So we took patients, we took respondents who said that they'd had a confirmed diagnosis of COVID-19, and they were then asked to rate their senses of smell and taste. So smell was worst affected. We asked them as best we could about true taste, and this was not far behind. And then some were experiencing something called chemesthesis, which is a sort of tingling or burning sensation in the nose and the mouth. What we saw was that within COVID-19, reported smell distortion seemed to be relatively rare. And obviously this was a smaller proportion, and we've got a bigger data set that's now available, and we'll see what the updated results show as we go along. So just to talk about sort of what's out there in the field at the moment, colleagues sort of around the world doing various things. So over in Florida, there's the University of Florida Smell and Taste Center. They're doing some great work looking at gene therapy, and they've done some work in sort of mice models, being able to sort of restore smell perception by some of the work they've done in that, into the mice model. So I guess the next challenge for them will be to translate that forward into a human setting. Dresden, obviously, which is, as I mentioned before, where I went to sort of learn my skills around smell and taste disorders, a key focal point for smell and taste research in Europe. They've been doing various bits as well about the genetic basis of variations in human smell perception, looking at correlations of smell function in children and adults between various things that they can look at on things we call functional magnetic resonance imaging, which is a way of looking at brain activity live. They do a lot of work around smell training, and have also looked at the significance of these smell distortions. We talk about parosmia and phantosmia, and that we're just in the process of trying to get a paper published that shows that parosmia can actually be a good sign of recovery in people who suffer post-viral smell loss. Over in the States, you've also got the Monell Center. They've been a sort of another big center for many years in Philadelphia. They've done some interesting work around nerve stimulation. I've had many people contact me about this electric shock treatment to the olfactory bulbs, which is slightly kind of interesting, and I think requires further validation before any sort of conclusive results can come from that. They appear to be doing some work on the effects of ethylene exposure, and there's a YouTube link there for when Duncan, our founder member, went over and did a sort of engagement event with them around patient engagement with their research.
And is the ethylene exposure a cause or a treatment?
I think it's looking at sort of cause. I think it's looking at sort of people exposed to it in a sort of industrial setting.
Got it. Because we did have a question about that earlier, saying that, in the same way as we have sort of loud noises can impact our hearing, are there loud smells?
Yeah, I guess there are loud smells. I mean,
it flags up the challenge we have with language in this whole area.
Yeah. Yes, I mean, I think obviously that's often an individual experience to some degree, and some people may have individual sensitivities as well. But there can be things that people are exposed to, sort of chemicals which may cause people's sense of smell to be deteriorate. So what we call a sort of toxic rhinitis. So particularly people in sort of an industrial setting where there's sort of particularly volatile chemicals that they might be exposed to. And there's a huge list of things that are out there people might have exposed to in the past. So some of those can be relevant. One of the other things we do is we have a clinical olfactory working group that was set up, includes many of us that participate in Thomas Hummels Smell and Taste course every year as the faculty. So basically a whole group of clinicians that all run smell and taste clinics like myself around, particularly around Europe, but also around the world. One of the things we did at the beginning was to write this thing called the position paper, which sets out the kind of basic standards for care for patients with smell and taste disorders. So what clinicians should be thinking about doing when people present with these problems. And it's a sort of platform for us to discuss collaboration internationally. And we've just started recently doing a journal club where we discuss sort of current ideas in the field and sort of brainstorm between us. And we're about to hopefully put out a publication very soon when I finish doing the draft about treatment guidance for post-viral smell loss. Colleagues of mine based down in London have been running a study called Predict Parkinson's Disease. So for those of you not aware, smell loss is a extremely common symptom in established Parkinson's disease. So at the point of diagnosis of Parkinson's, and Parkinson's is diagnosis on clinical signs, so it's not there's no single test for it, but it's people get this typical tremor. They get a particular way of walking and a sort of shuffling, and the neurologists, when they diagnose this, find that 90% of people have lost the sense of smell at the point of diagnosis, and that probably happens up to about 5 years before the onset of those signs. So we've been working with them because we believe that some patients who we don't find a cause for smell loss might be obviously in a sort of category where they're in that preclinical phase of Parkinson's. And so we've been sort of approaching patients who we identify as not having a cause for their smell loss and offering participation in their study. And then they take those individuals on and they run them through an online questionnaire. There's a keyboard tap test they do, and then colleagues from the research group come out and actually see the individuals in person. They do an examination and they video how they walk. So it's quite a detailed assessment. And we're looking in conjunction with other signs such as sleep disturbance and changes in mood and changes in bowel habit that might all fit together for us to recognize a sort of constellation of symptoms that allow us to predict more accurately people who might get Parkinson's further down the line. Now, there's a lot of research in Parkinson's that's gone on to suggest that we may have drugs around the corner that may prevent progression of Parkinson's. And so if we could actually identify those people earlier in the process, then that would be great if we can then flag them up and say, okay, well, we think you're going to get Parkinson's, so let's keep an eye on you, and then we can give you this new treatment once it's available.
Okay, we had a question coming in. It was related to, I know the Parkinson's wasn't always specifically with age, but somebody said, from Mabel, I understand sudden loss of smell can lead to dementia some years later. What's the current thinking of this? No, I think we've sort of got a cause and effect in there, which is sort of...
Yeah, so, I mean, the sort of data suggests that about 50% of people with Alzheimer's probably have smell loss. I mean, I was looking at this data the other night because I had a query come through, and if you look at some of the recent studies, you know, a lot of the people who experience smell loss have also got significant memory impairment. So there's a question as to whether they've forgotten what things smell like as much as whether their sense of smell isn't working. And when they've done smell tests, you know, often there's smell loss in both cases, but the more severely affected ones obviously have got memory impairment as well. But yes, I mean, there's a common association there. Now, whether again, it's sort of a predictive sort of value to that, we're not sure, and there's certainly further work to be done in that field.
And just briefly, somebody else asked a question. It was around, I think, the macro, but it goes across all of these. If people want to get involved in this research or feel they'd be a good part to be able to contribute their experiences into the research, what would their route into it be?
So we've got hopefully links to all these things on the Fifth Sense website. If you go on the Fifth Sense website and you can't find them, definitely let Nina or Danny know at the Fifth Sense office, and we can make sure those are added. In fact, Nina and I are due to have a sit down and just go through the research tab of the website and make sure it's up to date. I also have links to stuff that I'm involved with on the UEA website, which is uea.ac.uk/rhinology-group. And that's the list of projects that I'm involved with. And there are also links there to the surveys, which I mentioned previously.
Thank you. Go for it. Yep.
Okay. So I guess in a nutshell, I think one of the things I've sort of encapsulated is that there is a need for more clinical trials in this field, and this is, you know, where we've really been lacking in terms of the research been done to date. Now there are, as you can see, lots of publications out there around various potential treatment options in this field, but if you look at the number that have actually been done as what we call double-blind studies or a randomized controlled trial, they're very few. So the scientific rigor of the studies that have been published to date is lacking. And MAPCO obviously is one randomized controlled trial that we hope will put some rigor there. I'm in the process of waiting to hear on some funding around vitamin A as a treatment, which Thomas Hummel's group has done some early work that suggests it might hold potential benefit, and certainly within our clinical olfactory working group, a lot of us feel that it has potential, but we need to do some further research to underpin that, and that's something I hope to be seeing funded in due course at UEA. So yeah, this is a key area, and this is something that I guess I'll be sort of throwing into the melting pot as part of the priority setting partnership. In terms of, as I mentioned, I was talking about vitamin A, sodium citrate, something that both Thomas Hummel and I have done some work with. Again, has shown some early promise. We think it has a short-term effect on improving smell, but what we need to do is some studies that look at longer-term data and longer-term outcomes from using that. A few people have contacted me in the past about some research that came out on platelet-rich plasma being squirted up the nose. The study's been done so far. The one study's been done so far had 7 patients in it, and as you can imagine, a study with 7 patients in doesn't tell you a huge amount. So there's definitely a lot more information needs to be gathered around that before that can really be thought of as a sort of a definitive intervention.
Just a trial-related one. Sorry,
yeah.
just Gay chopped in a question about link between anosmia and Parkinson's, and I know you sort of touched that briefly. Is there a link between anosmia and Parkinson's?
Absolutely, yeah. I mean, well,
yes, on that one. Yeah.
The 90% of people with clinical diagnosis of Parkinson's will have anosmia. So it's inherently for the majority of people that experience Parkinson's have no functioning sense of smell.
So for people above a certain age bracket, perhaps it would be wise to have what would they do? If I was, say, sort of 70 years old and losing my sense of smell quite suddenly, would it be worthwhile having a chat to my GP about Parkinson's as well?
Yeah, absolutely. I mean, I think in terms of losing sense of smell, having that sort of screened and looked at, and so what we typically do is we look at those patients, we evaluate them, we confirm the sense of smell is missing, we do any investigations to rule out any other underlying causes. If all our investigations come up normal, we can then say to the neurologist, actually, this might be someone who should follow up in terms of thinking about Parkinson's.
Thank you. No, I sort of plucked out the age 70 years old, but I actually know somebody who's happened to who's considerably younger than that. So
yeah, I mean the study, the PREDICT-PD study, is looking at 60 to 80 age bracket. That's the sort of typical sort of age range. But yes, you're right. I mean, obviously, I think that's Michael J. Fox was the sort of famous case of someone who acquired it in his 40s.
Just as sort of some general comments, be interested to hear your thoughts about it, as we sort of at this point might not be the right point to pop it in, but just sort of that frustration. Kieran pointed it out. Kieran, I'm sure it's something we all feel that you've voiced in there. It seems that smell loss is a precursor to maybe so many other conditions and a lasting side effect of many more. So why is there so little understanding in the medical industry, medical profession industry, slip of the tongue, the medical profession overall? And you've been out there in the forefront talking about this, getting in touch with people. Where is the resistance? Why? What's your own just sort of broad overview of that?
Yeah, I mean, I think the problem is that it's long been seen as a sense that has little importance, and not just in the medical sphere, but in the sort of public domain in general. So it's an undervalued sense in the first place. You then add to that no one's really taken ownership of it so far in the medical profession until more recently. So although it comes under the banner of ENT surgeons, they've generally not taken much of an interest. Hence why setting up a clinic to deal with these disorders was a crucial thing from my point of view. I remember lots of comments when I was a trainee about, I was giving presentations on sort of, the research I was doing, and people were saying, oh, well, that's great, Carl, but, why are you bothering? Because there's nothing you can do about it. And that's a general philosophy has been present sort of, over many years. And so, one of the really sort of crucial things that we've been doing for Sense is trying to educate sort of clinical colleagues to say, actually, this is important because it's one of our senses. People lose it, are really kind of devastated to lose it, and therefore we need to take this situation more seriously. And yes, we can't at the present moment in time treat everyone, but we need to be able to kind of empathize with them and make sure that we've given the best chance of at least evaluating it, if not seeing if there's a treatment available. Yeah, and you know, the other I guess the other sort of key specialty is neurology, and you could argue that neurology should potentially have a stake in this, but generally, again, it's something that neurologists tend to neglect. The recent work that I've flagged up, the sort of paper that we're waiting for a journal to review at the moment around barriers to healthcare, showed that neurology as a specialty were often quite dismissive of symptoms of smell loss, perhaps not ENT. So yes, that's a common problem. So yes, I'm hoping that the landscape is changing, but it is very frustrating, and it's that sort of, you know, the kind of sense of frustration amongst clinicians that it's not something they can't do anything about. Therefore, why bother?
Yeah, and I mentioned it a few times, and I know I said at a Fifth Sense conferences about who's been on the receiving end of a shrug from their at least sort of their frontline medical GPs, perhaps. Just give us a wave if you've received a shrug from the medical community at some point. A very common experience again. Thank you. And I say something at the end, Carl, but I appreciate all your work on behalf of all of those shrugs that we've been on the receiving end of, that you went past that yourself and even had that discouragement. Thank you. Future promise. Sorry, we sort of interrupted you on this particular point.
That's okay. Well, so I think I've covered the PSP, and I think that's going to be a big sort of factor in how we shape things going forwards. So definitely, you know, more trials. We need to work hard on doing those. But I guess we also need to be able to do a bit more work around understanding, you know, what's happening at a microscopic level in some of these conditions, to be able to kind of look at what those trials should involve and what new treatments we might be able to take on board. Certainly, as I've alluded to, stem cell and gene therapy research holds some promise in early animal models, and I think we will see good developments in those fields going forwards. I mentioned about COS and the macro trial, but the other area, I guess, which is now a key area of development is the biologic drugs. And basically, these are injectable drugs that we call monoclonal antibodies. And they're a new way of treating conditions such as chronic sinusitis and also asthma. And they basically sort of latch on to sort of receptors in the inflammatory pathway and try and block the process of the swelling that happens in the sinuses or in the lungs in the case of asthma. And there really might be sort of change in the landscape of how we treat patients with this condition. Now, the only problem at the moment is that a course of treatment for one of the new biologic drugs is about £10,000 a year. So as you can imagine, the chances of me prescribing that for most of the patients in my clinic is negligible at the moment, but those costs will come down over time. So in fact, last week I was actually part of an advisory board discussing how we might get the NICE, which is the National Institute for Clinical Excellence, to take on board recognising some of the new biologic drugs as being available to treat severe cases of chronic rhinosinusitis, and that's particularly those who have aspirin sensitivity and asthma present as well in the background. So I think that's an area, and so I think the macro trial and the biologic drugs will help to shape improvements in the experience of patients with chronic rhinosinusitis.
And just one quick question from Kevin. Yeah. I saw you have your hand up. I'm glad you found the chat box. Some of these, now, I don't want to make sure, is there anything people can safely try at home? For instance, taking vitamin D, for example, which would, you know, be worth a try. And Kevin's asking, for instance, about sodium citrate. Is there anything there that's available that, you know, outside of the programs, that wouldn't interfere with other medical treatment, that wouldn't shortcut assessment for something more serious in the background? Are there anything that's gone up on screen so far that people could try for themselves?
I guess it's a little bit sort of causation dependent, I suppose. So it's about sort of being sort of sure of what the cause of smell loss is in the first place. And I guess if you're not sure, I'd probably be encouraged to seek medical advice first. Obviously, the simple things that you can try would definitely be smell training. You can't do any harm with that. Only good can come from using that. Nasal rinsing is unlikely to cause any harm. It's a simple thing you can try. So if you do have other nasal symptoms as well as smell loss, it's definitely a good thing to start with. As I mentioned before, vitamins, I think it's probably best to kind of work out that you've got a vitamin deficiency or sort of before planning and using those. But taking multivitamins over the counter, lots of people do, and you probably won't cause any great harm from doing so.
Thank you. Do you have more on this one? Are you finished on your?
The last thing I was mentioning was just to say the last thing on the slide there is olfactory implants. I mean, in the specialty of ENT, we have cochlear implantation for people who can't hear,
Yeah.
And those have been available now for some time, and we identify both children who are sort of born without hearing, but also in some cases adults are available to get for acquired hearing loss to get cochlear implantation. And we don't have that for smell. It's principally because the process and the way that smell works is more complex. And so I know that there's some early work that's been started in the States to try and look at this. And perhaps in the next couple of decades, we may see some advances. In the industry field, there are electronic noses available that can sort of recognize chemical configurations and sort of say, this is a particular odor. So whether there's some process of translating that into an electrical impulse that allows us to recognize that instead of when the normal pathways aren't working remains to be seen. But yeah, it's a long way off yet, but it's perhaps something that yields promise in the future.
Thank you. So a few questions, just to a bit of a catch up on them. One where, what sort of routes do you take, or do you advise, or have you seen provide benefit where people have an unknown cause, whether that's either it's probably a virus response or it's congenital. So the idiopathic one, such a frustrating. I know that sometimes actually, I don't know, when we have interactions with the medical profession, we would like an answer, even if it's a bad answer. Finding the I don't know answer is a very, very tough one. What are the approaches you take for unknowns?
Yeah, I mean, the unknowns one's a difficult one because obviously you've been through the process of investigation and you haven't elaborated a cause. The context that'll depend a little bit on the age of the patient, and I guess once you're over the age of 65, obviously there's a chance that if you've established there's no other underlying cause, it may just be that it's an age-related phenomenon. And unfortunately, of course, as we're aware, that happens with all our senses, and the sense of smell is no different to that. So we have to be mindful to that. I guess particularly in more younger patients, if there's no attributable cause, I always offer patients the chance to be proactive and explore treatment options, because it is possible, and we've seen this again with coronavirus, is that you can have viral infections happen and smell loss may be the only symptom, and so you're not aware of any other manifestation of that. And if you look at studies been done in the past to look at what they talk about the iceberg, and the tip of the iceberg is the people experiencing the symptoms of a cold, and there's all the other people that are kind of getting infected with the virus without realizing it. So there is a subclinical sort of group of people out there, and they may get smell loss in isolation. So I always talk to people about exploring options that we might consider for viral smell loss, and I would certainly not sort of want to give up hope in those individual cases and those circumstances, depending on the sort of risk benefit to those individual patients in context of their own circumstances and their own medical history.
Thank you. Just touching on that, a question from Chris. Just what are the chances of recovery? So has Carl had much success from whatever treatment, i.e. what percentages within his own clinic for total recovery from post-viral?
Yeah, post-viral is probably after chronic rhinosinusitis the next sort of one on the list that's kind of most likely to recover. If you do nothing at all, the studies suggest that 1 in 3 patients will get spontaneous recovery. And that's looking at, I guess, the patients who present to us in the first place, because there's probably a whole group of people who get smell loss after a virus and it persists for a bit and then it gets better before they even come to our attention. But for those that kind of come to ENT attention, then about 1 in 3 get sort of a spontaneous recovery. Our data suggests that we can probably improve that up to sort of about 50% with interventions, but there is obviously quite a bit of variability about as to which people respond to which things, and we work through sequentially to try things that I've alluded to in that list I showed earlier of things that have been looked at in studies before, and until we get sort of better data from randomized controlled trials, it'll be, when we start to get that information through, we'll be able to probably signpost people better to specific things to try as we go forwards.
Thank you. And just sort of in the same area, Alison, I'm guessing this is post-viral, time frame for spontaneous recovery. So that's a very live one. I know I was just chatting to somebody earlier who's seen this come a lot in post-COVID recovery groups, especially known as the long haulers, who are still experiencing smell and taste either loss or disorders, and disorders I understand is quite common. What sort of, I mean, for COVID, of course, it's very early days to be able to tell, but in other kind of viral loss, what's a kind of a time frame that people can hang in just to see how it develops?
Well, so the studies that I mentioned before have looked over a 3-year time frame, saying 1 in 3 recover over 3 years, but it's not to say that there isn't no sort of greater range of recovery. I guess the further away you go from the original insult, the original infection, the less likely things are to recover. But I usually sort of say to people that once 5 years has elapsed after the original infection, the chances of recovery are probably pretty slight.
5 years on that one. Thank you. And for those who have had treatment, a couple in for FESS, maybe if you could just briefly tell us what that stands for. But a couple of people who've gone through FESS and then had also nasal steroids and have had either some or very little improvement. What's the next step after you have these sort of major pieces of treatment people may have gone through?
So FESS stands for functional endoscopic sinus surgery. It was a term coined by the late Professor Heinz Stamberger, who was one of the leading pioneers of sinus surgery, and it was thought at the time in the 80s when the term was coined that this was going to be the miracle way to sort of solve all people's sinus symptoms. I tend to refer to ESS, we just call it endoscopic sinus surgery. And really, for me, the goal when doing sinus surgery is about maximizing the potential for post-operative medical treatment to have its impact. Sadly, the term FES or ESS is an umbrella term under which there is a massive range of component bits that can or might not be done. And when I look at typically at the cases that I get referred to me that have already had FES done previously, often the scope of what they've had done is quite limited. So for instance, the case that the patient I operated on this morning had previously had FES done, and all I really saw was a few bits of scar tissue inside the nose, and none of the sinuses were open. So mostly what had happened was a few polyps had been plucked out during the previous procedure. So the last time this was looked at in any detail was something called the sinonasal audit in the UK, which was done almost 2 decades ago now. And they looked at the extent of surgery done, and a large proportion of people had quite a limited amount of surgery done during the operation. Now, if you ask those of us that sort of practice a more detailed extent of surgery, we would say that you should tailor the surgery to what you see on the CT scan that you do prior to intervention. Now, in terms of evidence, when we started the macro trial, the trial we really wanted to do is to say, is limited surgery or limited ESS or just a polypectomy inferior to doing a more extensive procedure? And the problem was, starting at that point, was that we hadn't got a trial that said sinus surgery was better than medical treatment. So that's where we had to go with macro. I hope that in the due process of time that we'll be able to do the next study to say, can we show that more extensive sinus surgery is better than more limited sinus surgery for better long-term outcomes? Certainly that's my experience as a surgeon in the field. And I know that others, such as the centre I was trained at in Vancouver in Canada, like to sort of emphasize that practice, but the jury is out in terms of the trial-based evidence. But I would say to anyone that's experienced sort of, limited improvement from previous intervention is what was the extent of that procedure? Is there scope for more to be done? Perhaps to go back and to be reevaluated.
Thank you. So I'm really hearing from a lot of your responses about how much of this is still in process of being researched. That really backs up just the recency of this and how much focus is being put on it in the last 10 years, especially. And still astonishes me, as I said at the beginning, that for the first time. One of the questions as well, a couple of people have, so we've covered bacterial viral smell loss, trauma and head injury, any routes of treatment that people can have, any other therapies, for example, that can be helpful or can provide some sort of benefit?
The difficulty with what we call post-traumatic smell loss, that's after a head injury, is that there's a range of severity, and of course underlying that is a range of where the problem has occurred. So it might be that there's been injury to the brain where you receive the signal, so there's been bruising of the brain. It might be that there's kind of been dragging of the smell sort of pathways across the rough skull base that's caused injury there. It might be that the very thin nerve fibers that penetrate the base of the skull from the nose into the brain have been torn as part of the process. It's also possible if people have had a nasal injury at the same time, that they've actually got some structural issue inside their nose that's contributing to the problem as well. So again, there's no sort of one size fits all approach, and I think every case has to be taken on its merit. One of the key things for me when I see people is that I test the smell to see what the baseline is. I look inside their nose to see is there any problem with the nose itself, and I do an MRI scan to see what is the extent of any damage inside the brain. And that gives me a better picture of where we're starting from. People have got sort of significant damage to both sides of the brain. The chances of that sort of recovering is probably pretty small, because those changes are pretty permanent. If the scan looks normal and the examination looks normal, then it may be that there's been some microscopic damage to the nerve fibers you just can't see, and that can over years, and I say years because the studies that looked at long-term recovery from smell loss, we've done over up to about 10 years, is that perhaps a third of people will get some improvement. Particularly if you haven't got changes on the scan, that may well just need a bit of time. Again, smell training has been shown to have benefit in these people. Some of the medical treatments that have been tried have included mixed group of smell loss patients, and so we saw in the sodium citrate trial, 1 or 2 people with head injury got some improvement, and 1 or 2, I think, in 1 or 2 other medical studies, there have been some patients with head injury that had improvement. There was a study in Taiwan that looked at prednisolone and zinc as a treatment and found that some patients got improvement. So for the right patients, there may be things that might be worth trying. So it should be on a case-by-case basis.
Thank you. And another question which has come up a few times, and you mentioned it very quickly, to say that actually parosmia can be a little sort of mark on the path towards some kind of recovery. Parosmia, when people get distortions. And again, sort of in terms of recent context of COVID, this is one which has come up a lot as well. Your thoughts on that?
Yeah, so parosmia or smell distortion, when it happens after viruses, we believe is because the virus has knocked out some smell receptors. And so what happens when you're smelling things is that if you take, for instance, the smell of a rose, there's probably about 13 individual molecules that you smell, and you recognize the pattern. And if you're missing 7 of the receptors that allow you to recognize the smell of a rose, then it'll come through as a distorted signal. And that distortion always appears to be unpleasant in most cases. But the fact that you're getting some of that sort of signal is a good sign, because it means something's working. Whereas if you get nothing at all, then it means nothing's working. So, and we've said a recent bit of research we've done as part of the clinical olfactory working group suggests that those patients who develop parosmia in the early stages often then go on to develop some degree of recovery. So So we would say the fact it's sort of you're getting distortions means that things are starting to come back online. So the people that particularly should work on smell training and really sort of try and sort of enhance that recovery process.
Thank you. Let's just see, catching up anything else that we've come into. Any other questions? Do pop them into the chat box. One question around the impacts, and I know this is maybe slightly out of your area, but because I imagine it's a very, very important part when we come and talk to people in the medical profession. Of course, I wouldn't come to you expecting you to be a therapist, and of course I know that the understanding that you can offer is really important, but if people do want more support in terms of psychology of the impacts of this, have you found any particular people to talk to, any particular research that's gone into this that can just back up that feeling that we have for those who've lost or partially lost our sense of smell, that this is just getting that acknowledged even can be really important for us.
It's a really important point, and I would love to have a psychologist sat in my clinic with me who would be able to kind of talk to people around the impact of smell disorders. As yet, it's something I haven't been able to sort of to do. But one of the things that we're looking to do at FISTENS is to try and develop a psychological support package process, and that's sort of work in progress. And so I hope that in the not too distant future, that's something that we'll be able to really kind of bring forward and offer to people, so that I can sort of say to people when I see them in clinic, okay, look, there isn't necessarily someone here now, but there is a process you can go through to get that support and to get psychological input. And I think that's really crucial. I think that's such an important part of managing these conditions.
Thank you. A quick question in from Alison around parosmia, saying that is certain foods tasting horrible a version of parosmia? And I popped a question in saying any particular triggers, and Alison's come forward with one, which again I've heard from other people being a big one: garlic and onions.
Yeah, people always talk about garlic and onions. If I had a pound for every time I heard about garlic and onions in my clinic as parosmia, it's a very common one. I don't know why those were particular ones. I guess because they're often sort of pungent odors and probably sort of trigger things more. Whether those particular receptors that help pick up those things are more vulnerable, I'm not sure. But yes, I mean, people. One of the key things about parosmia is the process of eating that's often disrupted most, because it's often around food odors that people feel revulsed by certain smells.
Thank you. A couple of other questions coming in. I'm just questions do come in. Hello, is that your dog, Carl?
Oh, it's my dog, so yeah, I'd telling me my time's up.
Yeah, no, I think we're pretty well there. Anything else coming in for Carl? I try to cover off as many different questions as possible if there's anything else. Coming in, I'm just trying to have a look through the chat box while I'm talking. Weight loss and weight gain came through as a particular issue as well.
Yeah, that's common. One of our previous publications I flagged up earlier showed that a third of people experience weight loss, a third experience weight gain, and about a third manage to steer through a steady weight. So some people find that they just lose interest in food, don't eat as much. Some people go for the kind of stimulation from sort of fast food and takeaways and gain weight from unhealthy eating habits, and the rest seem to kind of manage to find a steady path through.
Thank you. Quick question in from Yasmin. I'll take yours as the last one. Any particular studies focusing on congenital anosmia, i.e. anosmia which comes from before people have any particular memory of having a sense of smell? Having had toddlers, I was surprised any of them get through without such severe head injuries from all the falling off down they do while learning how to walk. Any particular studies on congenital anosmia, or does this
I mean, there are studies published on congenital anosmia, largely sort of characterising it in association with Kalman syndrome, where there's an associated lack of production of certain hormones in the pituitary gland of the brain. But in terms of treatment, I guess no. I mean, there's been again some early sort of animal model work where they've grafted olfactory bulbs in a rat model, and perhaps there may be something that in the future may be an option, because these people are usually missing their olfactory bulbs, so it's like the relay station where the smell nerves kind of connect at the top of your nose. So the patients with congenital anosmia typically have those missing. But yes, I mean, no, it's a, I guess it's it's probably about 1% of all smell disorders, and probably, you know, the least research component of an under-researched field, unfortunately.
Thank you. So, well, just as we come to any final comment, just to let you know that this is a part of, we had a question in earlier saying, do we have any regional get-togethers for the UK for giving support? Well, these particular sessions came in as a replacement for a large program that Philpott had in place to really help get people to get that support, get and talk to each other. As a lot of you said, especially in the early part of the chat, so important just to be able to sit and talk to other people who really get it and understand. And after 20-something years of my own personal level of smell loss, my contact with Fifth Sense was the first time I could really do that. So really know what that importance is. We have a set of different activities, a set of different talks that we're going to have available. Very simply, to get this, do just look up the Fifth Sense website. Oopsie. There it is, it's sharing. And here's an example of them for the program of different activities we've got. Some of them will be a bit like this, where we have an expert speaker, such as Carl, who's going to be doing another one as well, I think in December. Others of those are much more interactive sessions where we have a chance to talk. And the small ones, which I'll be running, just called Impact of Smell and Taste Loss, they're almost very much a community event for us to work together, talk to each other, share our experiences with each other. So a lot of variety of types of activities that we will be doing on these Zoom sessions online. And any other resources, I put different links on there in the chat box. There are links to clinics. For those of you in the US, I put in, just pulling up ideas in the USA. I totally get that there is a real need there. If anybody does have any extra links into US resources, US clinics, US physicians which are sympathetic, please do pop them up in the chat box and keep an eye if that's information that you want. But with that, thank you all very much for being here. Thanks for your questions. Thanks for your fantastic amount of input we've had in the chat box. Do be in touch to Fifth Sense if there's any support we can have. Thanks then. Bye-bye.